podcast Collaboration Over Competition. During that podcast, I will be visiting my colleague in different clinics to discuss subjects about plastic surgery. Today we're in Chicago with Dr. Placik, and I'm honored to have him on my podcast. So thank you.
Well, you're welcome. We've known each other for a long time.
I know. So we'll be discussing one of our favorite topics, labiaplasty. So this is a surgery that you perform quite often, right, in your office, and you have been for a long time now.
Since at least 2005.
Oh my God.
So it's a long time.
So longer than me, for sure. So what is the most common reason why patients are coming to you in your office here in Chicago for labiaplasty?
So that's a great question. Early on, I was wondering, why would they come to a plastic surgeon? When this first started, there wasn't much about it. There had been on some TV shows like 90210, Nip and Tuck. I didn't even know what it was at first. When they said labiaplasty, I thought naturally it was a lip or a chyloplasty. So I had to look it up, and I was surprised because I had done some congenital adrenal hyperplasia at Children's Memorial Hospital. And at first, I sent most of my patients to my gynecological colleagues, and they did not want to do it. In the Midwest, it's a little bit more conservative, and they refused to do it. And after a while, the patients would bounce back to me, particularly ones they already operated on and trusted me, particularly some medical personnel and nursing staff.
And then for revision,
And later for revisions, because it was, when I started doing it, there weren't that many people doing it at all. In fact, I sent them to Dr. Alter in California, and they didn't want to go there. And he was the one who had really written about it in 2007, 2008. I mean, his articles didn't come out 2007, 2008. So I didn't even know where to go to. There were very few articles, very little literature on the subject. So I wasn't sure, and you kind of had to read more about it, and there wasn't a lot about these procedures. So the patients that came to me, I think, were predominantly, they're self-selecting. When they came to a plastic surgeon, I still to this day I send them a questionnaire saying, have you discussed this with your gynecologist? What did they say, and why are you coming to me? And for the most part, they felt that a plastic surgeon would better serve their aesthetic needs. So I think that if someone were having true functional or, what we say, dyspareunia, pain with intercourse, or ulcers, or other medical conditions, I think they would go to their gynecologist, and typically that would be covered by insurance.
Exactly.
But when they came to me, they were self-selecting. These were really people who wanted an aesthetic improvement. Now we know through many studies, like through Dr. Furness's study, that it's a combination of both. For most people, it's both aesthetic and functional.
So that's the thing with labiaplasty. Not only we do cosmetically a good looking labia, but also functional. So how do you explain to your patient that, like, which aspect will you be working on, like more functional, more aesthetic, or it's always a combination of the two?
I think it's a combination of both. And I think, first of all, I'm amazed at how little some of my patients know, and how much others know. So some people don't even know their own anatomy.
And some too much.
Yeah, and some too much. And so, some people don't even know where the clitoris is located, and so we have to educate most of them. I typically make them watch a 20-minute video where I cover the bases before I even examine them. So I know that they have a familiarity and, some basic foundation. Once we go through that, I then literally give them a mirror in my office, and I examine them first, but then I give them a mirror with a female attendant with me, and I point out the anatomy. And I say, this is the clitoral hood, this is the clitoral frenulum, this is the labia minora, this is the labia majora, this is the interlabial sulcus, this is the posterior labial commissure, this is the perineum, this is the vaginal introitus. These are the hymenal.
Full anatomy course.
Right, but it takes 30 seconds, and it's hymenal fragments. And in the course of doing that, patients will say, well, I don't like those things hanging out, and it'll be hymenal fragments. And not that I'm trying to encourage them to have it, but they will bring that up. And so in the process of educating them, they then say, well, I do want the clitoral hood reduced, or I do want the clitoral frenulum reduced, or I want the vagina tightened, which in case is vaginoplasty. Exactly. And they think, now interestingly, some people who have just a labiaplasty tell me that they have sensations of vaginal tightening afterwards, but it doesn't really tighten the vagina. It may cause some scarring.
Of the opening.
Yeah, of the opening a little bit. But for the most part, I tell them that's not going to tighten them. But again, going back, you have to separate your patients. Most of my patients, when I've done retrospective surveys, have been the average labiaplasty patient is a 26-year-old, nulliparous, meaning not having any children in the past, and it's predominantly, they're thinner than my average patient population. So I see that they have smaller labia majora, they are more groomed, which makes the labia minora, even if they're average sized, they're more visible.
Exactly.
And they're very active, and then they're subject to more friction or trauma. They are wearing thinner garments, and so they see it more. Versus, a mom is a very different situation.
Yeah, exactly. So. And for the surgery, we know that two techniques are there, mostly. The most common one, the trim and the wedge. Every surgeon have a favorite one. What is yours and why?
So I definitely stick with the trim. I think that I started with the trim. Like I said, 2005, I found it to have the lowest complication rate, which mainly is wound separation, and wound separation can result in tenderness. And so when people say they have pain from a labiaplasty, it's usually from an unstable scar.
For the scarring process, yeah.
Right, and I see that even patients have come to me after having a perineal tear or an episiotomy that didn't heal well, or a spontaneous labial tear during the delivery, and if they have pain, most likely it's an atrophic scar or an unstable scar that hasn't healed well.
Yeah.
But
so with the trim technique, you're limiting.
With the trim, what I say is that if a trim falls apart, it naturally will fall together. And it's just, I make the analogy to these lips. When you have chapped lips, you can see fissures and cracks. As soon as the swelling goes down, they come together naturally.
That's good. I may steal that one.
So versus a wedge, it's closed under a little bit of tension. And if that separates, it wants to go back to its natural. And you have a lot of notching. And then there's color differences. And so I find that in selected patients, I do like the wedge. And there's some patients where I do a trim on one side and a wedge on the other side. But unless it's really the central 1/3, and through the studies with the vascularity, that really the best place to do a wedge is anteriorly.
Exactly. You should not go posteriorly. Yeah.
You should not go posteriorly, but that's usually where most of the excess is.
Yeah.
And then I think what happened to me was in 2007, 2008, when I felt that I was being intimidated and I should go to the wedge. I did go to the wedge for 2 years, but I found out that 1 out of 4 patients were not satisfied with the amount of reduction that I achieved. And instead of saying, well, that's the most I can do, I ended up doing a revision on 1 out of 4 wedges with a trim. So then I said, so now I offer the trim unless somebody either really requests it or it does have a central 1/3 prominence or an anterior 1/3 prominence.
Exactly. So the two techniques are great technique. I think the wedge and the trim. I think it's mostly a patient selection, right?
Correct.
And also every surgeon, we know one technique and we love it. So when we love something, I think that's when we do good thing, right?
Yeah, I've been on panels where I've seen some amazing results with the wedge. And I say that's great, but
in my hands,
I think that my patient satisfaction is much higher, and my need to do a revision is much lower with the trim. So that's my go-to procedure most of the time.
And you're involved in a lot of labiaplasty, study and article. So what's coming in the future? What's next? Do we have new techniques, new tools?
I wish there were. I think it's more education. I think that when I started, I couldn't answer a lot of the questions, and patients were like, well, they lose sensitivity. And there's some sensationalist people out there that we all know of that say that they lost sensation, and while that's possible, I never had it, several hundred. And so I did a study where we measured sensitivity. Then people said, will I be able to have children afterwards? And I did a study with that, looking back, which was fine. Incidence of, puerperal tears were the same as the general population. Another one that I just recently completed was, will people be able to know? There was a concern. One of psychological studies said that people were reluctant because people thought that prospective partners may think that they had transgender surgery or gender confirming surgery. So we did a study where we showed 5 pictures of people who had not had surgery and 5 who did, and showed those 500 lay people as well as 15 gynecologists and then 10 people who did the procedure, and no one could really tell the difference before and after. So I think that answered it. So in a lot of ways, I think that, educating the public, educating my patients was where my practice has evolved to. I think as I'm looking at this and as people become increasingly more comfortable with their anatomy, I don't ask anybody to come in and say that this is the standard. But if somebody does not like that appearance, my concern is, I guess moving forward, is to address more of the components. And I think increasingly with patients getting thinner and on Ozempic and those various semaglutides and tirzepatide, is that they're losing fat from the labia majora.
Exactly.
Which I think increasingly, as my practice evolved, I'm offering more fat transfer
to the labia
majora as part of this. And so that is, I think, an increased part of the practice, or the advancements, is knowing the aesthetic goals. Yeah. And I think, understanding what can be reduced in terms of that interlabial sulcus, you can only reduce so much. And so that is, I think, when it comes to energy-based modalities, I don't really feel that laser, radiofrequency,
I don't think they will replace the surgery.
I don't think that they add any benefits, because a lot of time they aren't able to control the hemostasis. So you still resort to electrocautery in the end, even with laser energy-based modalities.
For sure.
So I have not found it. I've done one study with a popular radiofrequency device to see if we could do a non-surgical, and I found that we had to terminate the study because out of the 10 patients, we were planning on doing 15, 7 of them wanted surgery.
There you go.
It just did not achieve the
goals. So that's good,
goals.
because we still have our job.
Yes. So I think that, while it did produce some results in some patients, it was not predictable. And so I don't believe we're at a satisfactory non-surgical treatment yet.
So still good. Now, can you comment on the TikTok viral video of a woman saying...
Dr. Rachel Rubin.
Saying that at menopause, labia minora, they just disappear.
Yeah, they disappear. You'll lose them.
But you lose them where?
Right, exactly. That's sensationalistic. And, I really felt compelled to respond to her, and I did. And she did respond back respectfully. I think that she is a very educated and very well-intentioned surgeon, gynecologist. I think that statement was misguided and irresponsible. Nobody loses. They might have some involutional atrophy, and we know that estrogen, and again, going back to my pediatric experience with congenital adrenal hyperplasia, when you have the 21-hydroxylase deficiency, the hormones can cause the labia majora and the clitoris to overgrow. Similarly, when there's a withdrawal or atrophy or ovulation or genitourinary syndrome of menopause, you have a withdrawal of some of those hormones, and with that you may see some shrinkage, but they may shrink just like breasts do. They may atrophy just like facial skeleton does, with a loss of osteoporosis. And so you will lose some, they may shrink, but I've never had anyone where they fall off. And so I think that was sensationalistic. I don't think it was professionally responsible of her to say that, but it definitely got a lot of attention.
I know, and that's funny because this week I just did a labiaplasty on a 75 years old, and you know what? They were still there.
Exactement. People have that, and I think that sometimes those patients I do put on estrogen stimulation. Sometimes they have a little bit of atrophic vaginitis.
We need to be conscious about it, and I think it's just medically to be conscious about like the hormone, the menopause, and everything. But labia minora, they're there to stay.
Yeah, they do not fall off.
They will not fall off. And the last question, which is more philosophic: if you could stay at one age for the rest of your life, which age would you pick, and why?
So, I love the practice of plastic surgery, and I think it took me about 5 to 7 years to become very confident in my practice, which I finished around 31, 32, so I'd say around 37 was when things started humming in the practice. I had confidence, I had experience. I think nowadays I would be a little bit more aggressive in building my career. And I was a little bit more conservative at the time, but that was a good time. I had a family, I was providing for myself, and I think I was doing very well by my patients. And I really enjoyed that time in my practice.
So late 30s?
Yes.
Perfect, final answer, late 30s.
Yes.
Well, it's almost like it was yesterday, right?
Exactly.
So that's it for the podcast on labiaplasty, collaboration over competition. Stay tuned for the next subject, and thank you so much for having me in Chicago during that podcast.
Yeah, the big city.
Big city.